Hello, everyone, and welcome to the January 2026 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. I'm Alice Cheng from the University of Toronto.
And I'm Mike Rickles from the University of Pennsylvania, and we are your co-hosts for this podcast series.
So let me begin by wishing everyone Happy New Year. May 2026 bring good health and peace to all.
And I also want to wish everyone a happy new year and best wishes for the coming season. And in 2025, Alice, you gave us some fun facts each month. And what's going to be our plan moving into 2026?
So for 2026, I propose that we share fun facts about us that will not show up in any academic bio online. I think we'll maybe start off easy this month, Mike. I figured this might be a good way for our listeners to get to know the two of us a little bit. So here's the question for this month, Mike. In an alternate reality, if you were not a physician, and very importantly, no talent required for this actual answer, what would you be and why?
Well, that's a great question, Alice. And I think you're right. Pretty easy way for us to start because the answer for me will be ski patrol.
Oh,
You get cool gear and access to ski the mountain when nobody else can. And probably the most important piece is there's no need then to find excuses to go skiing. It would just be my job.
very cool.
How about you, Alice?
You know what, Mike? I did not know you were a skier. So I've learned something new about you. And we've been doing this together for how long? Okay, so for myself, and again, very important stipulation, no actual talent required, I would be a professional golfer playing on the LPGA tour. I do golf. I would not call myself a golfer, but I do golf. And currently, I have this love-hate relationship with golf. That brings me great joy and also great grief all at the same time. So it would be wonderful if in my next life I could potentially become a professional golfer.
Well, I know that feeling on the golf course all too well, Alice, and certainly think, there's always the senior tour ahead. So
Good point.
opportunities abound. So let's launch into the January 2026 episode of Diabetes Care on Air. This month, we are going to do things a little differently. Instead of each of us conducting an interview with authors of feature articles, we decided to do a group interview with authors of articles from a special collection that comes from the Diabetes Care Symposium held at this past ADA Scientific Sessions in June of 2025. The symposium was entitled How to Fix a Broken Healthcare System, and you can access the entire symposium for free on the Diabetes Care website now.
And we will still have our rapid exchange segment where Mike and I each pick 3 articles of particular interest to us.
Let's get 2026 underway.
Mike and I are thrilled to be joined this month by 3 of the speakers from the Diabetes Care Symposium that was presented at the ADA Scientific Sessions in June 2025, entitled How to Fix a Broken Healthcare System. In addition to presenting at the symposium, the speakers were invited to write corresponding manuscripts, and these were published in the January 2026 issue of Diabetes Care in a special collection.
We are joined today by Dr. Seth Berkowitz, a primary care internal medicine specialist and an associate professor in the Division of General Medicine and Clinical Epidemiology at the University of North Carolina at Chapel Hill School of Medicine. We had the pleasure of interviewing Seth before in a special episode that was released back in December of 2023, highlighting that year's Diabetes Care Symposium on Social Determinants of Health. And in the present series, Seth's article is entitled, What's Keeping the United States from Better Population Health? And so to get to the answer to that question, Seth, welcome back.
Thank you.
Now, in addition to Seth, we also welcome Dr. Marshall Chin, a general internist from the University of Chicago, the Richard Perillo Family Distinguished Service Professor of Healthcare Ethics, and co-director of the Chicago Center for Diabetes Translation Research. In this series, he was the primary author of the article entitled How to Fix a Broken Healthcare System: Pathways to Maximize Health and Well-Being for All. Welcome, Marshall.
Thanks for inviting me, Alice.
And last but most certainly not least, we welcome Dr. Mariana Socal, a neurologist by training and associate professor in the Department of Health Policy and Management at Johns Hopkins Bloomberg School of Public Health, with a cross appointment in the Johns Hopkins Carey School of Business. In this series, Dr. Sokol was the primary author of the article entitled Improving Affordability of Pharmaceutical Treatments for Diabetes, a Call for Action. Welcome, Mariana.
Thank you so much for having me.
So, as you all know, I'm not American, but rather a proud Canadian. And our healthcare system is far from perfect, but I wouldn't say broken, at least not yet. And for our listeners who are also not from the US, I encourage you to keep listening because some of the lessons and strategies that will be discussed are frankly going to be relevant to all of our healthcare systems, and no country has a perfect system. So let's start off with you, Seth. Can you briefly educate our listeners with some of the facts that may lead one to diagnose the US healthcare system to be broken, and also its dual problems as you describe it in your article?
Yeah, thanks. So, what I talk about is the dual problem is kind of two stylized facts. One is that population health is relatively poor in the US, and two is that spending on personal health care is relatively high in the US. And so, what I mean by population health being relatively poor is that, for instance, life expectancy in the US is far lower than in countries with similar economies and styles of government. It's falling faster, whereas other countries are holding steady or are even improving. Maternal mortality and morbidity is higher in the US and other countries. Various indicators of chronic disease, like the prevalence of diabetes and precursors like overweight and obesity, are higher in the US and other places. And so there's sort of a litany of factors that suggest the overall population health in the US is relatively poor, while at the same time we spend more, both in sort of an absolute dollar amount and as a percentage of gross national product, on personal health care than essentially any other country. And so that juxtaposition of poor population health with very high healthcare spending often gets presented together and is what I sort of term the dual problem in the piece.
And Seth, in your paper, you made an interesting point that although the dual problems are only partially interrelated, as there are some causes of poor population health that are unrelated to healthcare, and some causes of high healthcare spending that are unrelated to poor population health. Can you briefly discuss one of the causes of poor population health that is unrelated to healthcare per se, but also so very important to the success of a healthcare system?
Sure, yeah. And I think it's important because, these problems do get presented together frequently, and sort of the implication of doing it that way is, well, there must be some fix within the healthcare system that will make a difference. And to some extent, I think that's true. But as you mentioned in the question, I do think there are a lot of ways that these are not related. And so you're not necessarily going to be addressing both of the problems through a healthcare system approach. One thing that I highlight in the paper that I do think is a real explanation for why US population health is so poor is that in the US, relative to other countries with sort of similar economies and systems of government, people get exposed to material deprivation, poverty, insufficient income to a much greater extent than in other places. And you can see that both in sort of point in time snapshot statistics. If you just look at, say the child poverty rate in the US versus the child poverty rate as an average of OECD countries, it's usually 2 to 3 times higher in the US than an OECD average in any given year. But also when you think cumulatively, how people might be exposed over their entire life course, maybe in one year they're okay, but one year they're not. You see a lot more cumulative exposure in the US than in other countries as well. And I think this winds up creating a lot of health problems that then the healthcare system sort of finds itself behind the eight ball, so to speak, in terms of trying to address after the fact when people have already had these exposures that are very deleterious to their health.
Thank you for that, Seth. I mean, the social determinants of health are so very critical to the success of any healthcare system, and it definitely needs to be included in the conversation. So, Marshall, I want to bring you in now. what do you think is the fundamental problem with the U.S. healthcare system?
The fundamental problem with the U.S. healthcare system is that it does not prioritize the long-term health and well-being of all individuals and communities. It undervalues prevention of disease and complications. It provides inadequate access to health insurance and healthcare resources. And in fact, it imposes perverse incentives to avoid caring for under-resourced, marginalized individuals. The system does not do an adequate job of, as you and Seth said, of addressing the many social factors that impact the outcomes of our patients. And our system, it prioritizes short-term financial gain over long-term population health. The game for many healthcare systems is to increase the number of profitable, privately insured patients and increase short-term financial gain as opposed to taking actions that can improve long-term population health.
So we've got a lot of work cut out for us here, don't we? But we will get into discussing some potential solutions, I hope. And so, as a promise to the audience, we will go there. But let's continue to lay out the problems and contributors to those problems, first of all. And so I'd like to turn to you now, Mariana. Tell us about the problem with affordability of pharmaceutical treatments in the United States and how that impacts our healthcare spending.
Well, that's a great question. And to start, we in the United States, we pay on average 3 to 4 times higher prices than other industrialized countries for the exact same drugs. This by itself already shows us a red flag about how affordable can these treatments be. But in practice, the real impact is translated in that about 1 in every 7 patients living with diabetes reports they could not use the drug that they needed or the quantity that they needed, the way that it was prescribed in the last year because of price. And unfortunately, these are statistics that are maintained year after year. And so in the United States, affordability of prescription drugs, it's of course a problem that is most critical among uninsured, underinsured populations, among ethnic minorities, among low-income households, etc. But unfortunately, it is not an isolated problem. Affordability of prescription drugs, specifically for diabetes treatments, it's also a very significant problem in populations of patients who are fully insured. So how can that be even possible? Well, the issue here is that from a patient perspective, in the US, there's a very unique singularity in which patients are often required to pay a percentage of cost of their drug to get the medication. That's not common in other countries. And you can imagine our drugs, they are so much more expensive than abroad. Often these prices can be mitigated from an insurance perspective through confidential rebates and discounts. But those confidential price concessions, they are rarely, basically never, passed on to the consumer. So every time a person is required to pay a co-insurance, say for example, 20% of the drug cost, they are often going to be paying over the very high list price. They don't have access to the lower prices negotiated by their insurance. In many investigations that we ran here at Johns Hopkins, we also found that even if we account for these rebates and these confidential price concessions, we're still paying higher prices. That's because, we heavily rely on competition to lower prices in this country, and we have mechanisms that unfortunately have an unintended consequence. For example, patents, they have an unintended consequence from preventing competition from entering. So in some ways, it's like a perfect storm that keeps prices high and does not offer patients enough protection from these high prices.
Wow. Okay. So let me recap what we've heard so far. There's a dual problem of poor population health and too high healthcare spending in the United States. The healthcare system at present undervalues prevention of disease and complications and provides insufficient access to health insurance and healthcare services. And pharmaceutical treatments, which play a critical role in improving population health, are more expensive than they need to be due to a number of systems issues, and also what seems to me, as I was reading your article, Mariana, a problem of maybe a few too many players in the game as well. And on top of all this, there's the social determinants of health, such as social inequality, among others, that are sort of on top of all of this. So that is a lot in terms of issues that we've brought up in a very short period of time.
Now let's start to talk potential solutions then. So please tell us there are some ways to address all of this. And I'll go back to you now, Marshall. You presented in figure 1 of your article a conceptual model of policy actions to fix this broken healthcare system. Could you please walk us through that at a high level?
Sure, Mike. So when you look at the American Diabetes Association practice guidelines, there's a page that covers effective evidence-based population healthcare models that can improve overall health. These include elements such as team-based care that addresses medical and social factors. It includes outreach to patients who aren't contacting the healthcare system. It involves risk stratifying patients by medical and social risk and tailoring their care to their particular characteristics and risk strata. However, these effective population health models won't be developed unless we address a number of overarching policy areas. I'll mention four. So, first is payment. That money drives a lot of what happens in healthcare. So, we need to have payment policies that truly reward value and improving health equity and that provide upfront flexible funding that can be used to develop and implement these effective population health models. Second, everyone needs to have access to good, affordable health insurance. Third is ethics and culture. The healthcare industry, policymakers, and the public must truly value and prioritize health and well being of all individuals and communities, because unless the will is there and the values are there, we're not going to get there in terms of the policies. And then finally, and fourth, I'll mention political economy. That is, that we need to have fundamental political and economic structures that support a healthcare system that maximizes the health and well being of all. And one of the key elements of this is having principles of good governance, meaning that policymakers, decision makers should be transparent and accountable and responsive to the public, governed by the rule of law. They should have equitable and inclusive policies, and they should have policies that maximize social return on public investments. And in our article, we go through detailed recommendations in each of these areas.
Very comprehensive. Very comprehensive. I got to say, as I was looking through figure 1 and walking through it, it made a lot of sense. And I'm not an expert in the field, but as a clinician in healthcare, I mean, a lot of what you were saying made a lot of sense to me. So, Seth, what are your thoughts on this conceptual model?
Yeah, I like the model a lot, and I think Marshall and co-authors, really did us a service by putting it out there to reference. As you said, there's a lot in it, and so I can't even cover all the things I like about it. But one thing that I really like about it is that it emphasizes the importance of taking a life course approach, the importance of having continuity of care, the importance of sort of caring for an individual over the life course, because that's what leads you to emphasize prevention, emphasize management of chronic disease in order to prevent complications and those kind of things and avoid the fragmentation that we see a lot of. And I think to the point about how that points to solutions, one thing that I took away from the model is it really points away from thinking about allocating healthcare access through an insurance mechanism. When you think about what insurance is for, it covers, catastrophic rare events where, they don't happen that much, but it's really expensive or really bad when it happens. So you think of your car insurance and, hopefully you never total your car, but maybe, someone might have to, really make a serious car insurance claim once or twice in their life or something like that. Or, a tree falls on your house, hopefully never, but maybe only once or twice or something along those lines. And that maybe made sense when the insurance model was starting in the US, sort of circa World War II, when, people didn't get a lot of health care. It was a rare, expensive event. The main thing you're worried about was just being out of work and not having wages during that time. But now with modern medicine, there's a lot of preventive service we can offer. There's a lot of chronic disease management we can offer. And so healthcare is really something that's needed routinely on an ongoing basis and in a sort of continuous and coordinated way. And I don't think insurance is really the right model to deliver services like that. You think of other things that are like that, and you think of, say, primary education, like an elementary school or something like that, where people just need to access that routinely at certain points of their life, or things like fire and police services that just need to be routinely available for people to access. And I think we would think it's very weird if we had like one fire department for people over 65 and another fire department for people who are employed and a third fire department for people who are within the age where they could be working, but their income is below it. And it kind of just doesn't make sense that way. And so I think the model that Marshall and the co-authors put together, points us towards arranging the way we allocate the provision of healthcare in a different way in order to make sure that we provide, comprehensive, coordinated care for everyone across their life course.
I love that analogy of healthcare being an essential service, and I think something that everyone deserves, and we all would advocate anything possible to address the systemic issues that impede making that progress. And I want to take it back to you now, Mariana, on your call to action to tame the other beast, that is the affordability of pharmaceutical treatments. Take us through potential solutions.
Right. And I love that was mentioned before, how essential are pharmaceuticals for the management of diabetes. I mean, for individuals living with type 1 diabetes, drugs like insulin, they truly represent the lifeline for these individuals. And when Seth and Marshall are mentioning this life course approach, we can recognize how important it is to have access to these medications to keep patients out of the hospital, to keep patients safe and prevent complications, prevent additional events that, patients don't have to live with, if only they have enough resources to manage their condition. And so specifically, when we talk about affordability of pharmaceutical treatments, we have to think about ways to lower the price and make prices more transparent. That is the first step. Well, lucky to all of us, we already have one program in the US, the newly created as of 2022 Medicare Drug Price Negotiation Program. In its first wave, it selected 10 high-cost drugs in which those prices were negotiated for all Medicare beneficiaries. And out of these 10, 4 drugs were for diabetes. That shows us the impact of diabetes drugs from a budgetary perspective. And so these prices are going to come into effect in January 1st, 2026. So there's just a couple of weeks away. And they represent, for these 4 diabetes drugs, they represent discounts of over 79% of the list price of the drug, and almost half of the price after rebates and discounts for some of the drugs. So they are steep reductions. But that's not the only important part of this program. The second part that is really important is the fact that these prices are now transparent. They have been announced, they are in the public domain. So for the first time, at least in the Medicare program, patients, when they have to pay a percentage co-insurance, for example, or when they are in their deductible phase of the Medicare Part D plan, they can pay over the transparent lower price. So is that the solution for everyone? Of course not. It's not all drugs and it's not all patients. So some states have decided to pass laws that make those prices from Medicare available to other patients in the state. So that's another important piece, right? Which populations can we serve with the policy tools that we already have? Secondly, in addition to lower prices, we also have to think about lowering prices through competition. There are already bills that have been introduced trying to reform our patent system. What we really care about is secondary patents. Once a drug is already in the market, the drug was already discovered, it's already being sold. Why do we need to assert secondary patents that come down the line and allow these patents to prevent competition from entering the market? So these laws are not yet a reality, but there is already some movement towards having these types of policies be present in our system. Finally, I mean, the elephant in the room is called PBMs, is pharmacy benefit managers. These are intermediaries that really help when we talk about private insurance or some other insurance. Even in Medicare, they are present. These pharmacy benefit managers, they have a very important role to play, especially when designing formularies and negotiating prices. So there's also a series of reforms, for example, requiring a full pass-through of those confidential discounts and rebates to try to move towards more transparent and lower prices. That's still not yet a reality, but we also have some movement from a political perspective that could end up having these policies on the table and as a reality for all of us. So I think, we have many different ways that together could improve affordability, and it's up to all of us to support these changes.
Thank you. Thank you, Mariana, for that. So, listening to all of you, it's clear that there are indeed ways to fix this broken healthcare system. And all of you and your co authors and others have thought long and hard about this. And you've provided practical, thoughtful, detailed solutions in what you've told us on this podcast, but also within your articles. So, the question is, where do you go from here? And the other important piece is for the people listening to this podcast, you now have, hopefully, a number of inspired listeners, right? People who've listened to what you've said and said, you know what, you're right. We got to do something. I want to help. So, what do you say to them?
Well, I mean, I think one thing to keep in mind is that in the moment we're in, just continuing to care about these issues is actually a really important step that people could take. I think there's a lot of effort right now that is saying, don't pay attention to these issues, focus on something else. And so I think continuing to recognize that, social circumstances invariably shape health. How we organize and allocate healthcare, determines not just the overall level of population health, but its distribution, who experiences good health, who experiences bad health, and realizing that, even if it's sort of uncomfortable or unpleasant to talk about, this is just the reality of what affects people's health. Recognizing that means that you kind of have to stay in the fight, so to speak, and continue to work to improve health for everyone, despite, whatever may be pushing you to stay on the sidelines.
And Marshall?
We need to tell our legislators and policymakers that we prioritize the long-term health and well-being of all individuals and communities. We need to tell them that we care about population health and it is one of our key priorities. We should demand that legislators and policymakers explain how the policies they support lead to the improvement of long-term population health, as opposed to incentivizing a variety of healthcare organizations and industry actors to take actions that, at the end of the day, enlarge their own short-term financial gain rather than the long-term health of the population. On one hand, as Alice said, healthcare policy is complex. On the other hand, it's very simple that if we hold as the North Star the gold standard question, how does a policy improve the long term health of the population? That's sort of a simple guide that would cut through a lot of the fog. So, in some ways, it's very disappointing, the national discussion. As of today's taping, which is December 17th, 2025, as an example, the discussion around the extension of the Affordable Care Act subsidies is incredibly shallow and really avoidant, not really talking about what is this effect on long-term population health. We need to demand better of our legislators and policymakers.
And Mariana?
Demand better. I will absolutely second that. We should all advocate for health care, especially when it comes to diabetes treatments for patients, being very vocal about the problem. It's not by coincidence that we have had this important reform. It was the very first time that the Medicare program can negotiate prices on behalf of its 40 million beneficiaries. It's not a coincidence that we have had these bills about patents and PBMs introduced in Congress. That's truly about advocacy, and it's about being vocal about not only the problem of unaffordability, but also the impact of this problem in individual lives. Unfortunately, in the loss of life because of complications and exacerbations due to the lack of access to treatments, it's the loss of quality of life, living with complications, living with avoidable complications and consequences from having lack of treatment. So we should continue, we as providers, we as patients and families, we should continue to advocate for change. And now that we're so close to the threshold where for the first time we're going to have transparent prices in the US for some drugs. It's going to be 4 drugs for diabetes. They're coming in January. We should all watch and monitor, how much this will truly translate into change for patients, because I think that should be our guiding star. It should be to what extent patients are really benefiting from these policies, and we should not let it get away from policy agendas, maintaining the patient perspective as the priority here.
Well, there you have it. Final words of wisdom and inspiration from this esteemed expert panel. I love the lessons I've taken away on addressing population health that starts with critically understanding the social determinants of health in the population and considering the treatment of individuals across their lifespan, which is so important for considering the essential requirement for preventive services and when disease has manifested itself, as it has for our patients with diabetes, the access and affordability of medications and treatments that are known to care for their condition and prevent those future complications, and how the North Star should be guiding us to ensure these essential services are available for all those affected throughout our population. And that will not only lead to improved quality of life, life lived years, but also keeping our individuals affected by diabetes and other illnesses away from emergency treatment and hospitalizations and the real high cost, as we've learned, paradox of the poor population health that we have. And I really just appreciate all that you've taught us and given us and our listeners to think about in addressing this important problem for the United States healthcare system.
And I want to echo the thanks indeed. So I want to thank all of you, Doctors Seth Berkowitz, Marshall Chin, and Mariana Socal, for your time, your expertise, and I think most importantly, your passion on this topic, which I think comes out loud and clear. And for everyone listening, regardless of what country you live in, I'm pretty sure you can relate to some, if not all, of the principles that were discussed here today and take away learnings back to your own healthcare systems. I want to remind our listeners that there's actually an opportunity to watch the entire symposium as it was presented at the ADA Scientific Sessions in June 2025. I mean, here we only got a little bit about almost a half-hour teaser of the information that was presented, and there's a whole lot more that you can in fact listen to. And in it, you'll hear from other presenters, including Dr. Namratha Kandula and Representative Kim Schreier, along with a fascinating panel discussion. Also, I encourage our listeners to read the full special collection in this month's Diabetes Care, which includes an impassioned editorial entitled "The Forces Reshaping America's Health Landscape for People with Diabetes. This is not about DEI. This is about whether people live or die, DIE." So thank you, Seth, Marshall, and Mariana. Let's move on now to the Rapid Exchange segment, where Mike and I will discuss articles we found of particular interest this month. Mike, you go first.
Thanks, Alice. My first pick examines use of the dual GLP-1 GIP receptor agonist tirzepatide in adults with type 1 diabetes. Dr. Jennifer Snaith and colleagues from the Garvan Institute of Medical Research and St. Vincent's Hospital, Sydney, in Darlinghurst, New South Wales, Australia, conducted a 12-week phase 2 double-blind placebo-controlled trial of tirzepatide, 2.5 milligrams weekly for 4 weeks, and then increased to 5 milligrams weekly for an additional 8 weeks. Participants with type 1 diabetes and a body mass index greater than 30 kilograms per meter squared were randomized 1-to-1 between conditions of tirzepatide or placebo, and 22 of 24 randomized individuals completed the study. Tirzepatide was associated with loss of 8.7 kilograms or 8.8% of body weight over the 12 weeks when compared to placebo, with all those treated with tirzepatide losing at least 5% of their body weight. In addition, those who received tirzepatide had a 0.4 percentage point reduction in hemoglobin A1C and a 35% reduction in insulin requirements when compared to those receiving placebo. And in neither group were there any significant adverse effects, although adverse effects were reported more commonly, as would be expected with tirzepatide. And while this sample size is small and the observation period short, these findings support that while tirzepatide does indeed promote weight loss in individuals with type 1 diabetes, its effects may also be associated with significant improvement in glycemic control for this population in particular, and phase 3 investigation is currently underway.
Yeah, I really enjoyed this paper as well, Mike. And I think it's a reminder to everyone that just because someone's diagnosed with type 1 diabetes does not mean they're immune to developing overweight or obesity, right? So obviously they can equally get overweight or obesity like any others. And therefore, therapies that can be effective, like GLP-1 based medicines, could also be beneficial in this population. So yeah, I look forward to the phase 3 study. So, my first pick for this month is an important reassurance that we can do good whilst not inadvertently causing harm. Dr. Chan Mi Park and colleagues from Harvard Medical School performed a retrospective study to determine the effects of GLP-1 receptor agonists and SGLT2 inhibitors on frailty. They used a 7% random sample of Medicare data from the United States and compared new users of DPP-4 inhibitor, GLP-1 receptor agonist, SGLT2 inhibitor, and sulfonylurea on 1 year frailty progression, measured by a claims-based frailty index, which is based on 93 variables derived from diagnosis codes. A higher claims-based frailty index indicates greater frailty. They also utilized mediation analyses to determine if cardiovascular or safety event explained the differences in frailty progression. They found that GLP-1 receptor agonists and SGLT2 inhibitors had significantly less increase in their claims-based frailty index compared to DPP-4 inhibitor users, whereas sulfonylurea users had similar increase compared to the DPP-4 inhibitor users. In the mediation analyses, cardiovascular disease and diabetes-related complications did not explain the difference. Therefore, this analysis suggests that the use of GLP-1 receptor agonist or SGLT2 inhibitor were associated with significantly slower frailty progression compared to DPP-4 inhibitor after 1 year. Reassurance that we can do good, because we know these therapies do a lot of good for organ protection, whilst not causing harm.
I agree, Alice. These are very reassuring results for GLP-1 receptor agonists and SGLT2 inhibitors, although I have to imagine it being hard to completely remove the selection bias from prescribers feeling that DPP-4 inhibitors may be safer for some older adults due to having longer experience with them. And now, hopefully, that confidence will extend to these additional classes of glucose-lowering agents. My second pick looks at the use of teplizumab to modulate stage 2, or now referred to the pre-diabetes syndrome prior to type 1 diabetes development, in 2 individuals affected by autoimmune polyendocrine syndrome type 1, or APS1. APS1 is a rare monogenic multi-system disorder affecting central immune tolerance that may manifest in type 1 diabetes, as well as commonly causing hypoparathyroidism, primary adrenal insufficiency, and mucocutaneous candidiasis. In the present study, Dr. Christopher Wilson from Vanderbilt University Medical Center in Nashville, Tennessee, and colleagues studied 2 adolescents with APS1 and stage 2 type 1 diabetes who received clinically indicated 14-day courses of teplizumab therapy. Both individuals subsequently experienced improved glucose tolerance, reduced circulating populations of specific T lymphocyte subsets, and increased pancreas volume. These preliminary results suggest that teplizumab may have disease-modifying effects in type 1 diabetes, even in the setting of central immunologic tolerance failure, as occurs in those with APS1.
Very interesting, Mike. I think it's going to be fascinating to watch this field continue to progress, right? As we better understand how we could potentially help delay the onset of type 1, stage 3 type 1 diabetes, I should say. So this is very interesting. Thanks, Mike. My second pick dives deeper into personalized medicine. Dr. Lin Li and colleagues from Huazhong University of Science and Technology in Wuhan, China, performed a post hoc analysis of the lean time feeding trial to identify baseline multi-omic and phenotypic predictors of weight and body composition loss and regain, and then develop prediction models from that information. The lean time trial was a 12-week, 2x2 factorial, randomized controlled feeding trial, followed by a 28-week observation period. 96 adults with BMI greater than or equal to 24 were randomly assigned to control, healthy low-carb diet alone, 10-hour time-restricted eating alone, or a combination of healthy low-carb in a 10-hour time-restricted eating window. 88 participants completed the 12-week intervention. Using dietary, metabolic, fecal metabolome, and gut microbiome data, candidate predictors of changes in weight, body fat mass, and soft lean mass were identified. Multi-omic and phenotypic models were developed. During the weight loss phase and the subsequent observation phase, which was associated with weight regain, multi-omic and phenotypic models significantly outperformed phenotype-only models for predicting changes in weight, body fat mass, and soft lean mass. Specifically, certain gut microbiomes and fecal metabolites were strong baseline predictors. Therefore, baseline multi-omic plus phenotypic features, including the gut microbiome, fecal metabolome, dietary habits, and metabolic profiles, significantly improve predictions of individual level changes in weight and body composition during weight loss as well as weight regain. This takes us one step closer to personalized weight management strategies. Now, people are already used to clinics asking questions, taking measurements, drawing blood and urine, and it sounds like people better start getting used to sharing some feces too. Apparently, you are what you eat, and now you are also what you poop.
Yes, indeed, Alice. And perhaps this multiomic readout of our microbiota processing of our diet might soon replace dietary recall measures for really getting at specifically informed dietary modification. My last pick looks at using continuous glucose monitor or CGM system accuracy for integration into inpatient clinical decision support. Dr. Jill von Kanta from the University Hospital Essen and colleagues in Germany retrospectively evaluated 226 inpatients with paired CGM and point-of-care blood glucose measurements using the mean absolute relative difference, or MARD, and developed a patient-specific algorithm to minimize the MARD, and tested this algorithm in a second cohort of 24 inpatients. The initial MARD value was 10.3%, which I have to say is already pretty good for accuracy between CGM and blood glucose measurements. And this was improved by 4.33% when applying the patient-specific optimization algorithm. And that then was confirmed with a 5.58% reduction in MARD by the optimization algorithm in their validation cohort. So these results suggest patient-specific refinement of CGM data getting to MARDs in the order of 5% in terms of accuracy between CGM and blood glucose will really help achieve confidence necessary to adopt these glucose measures for clinical decision-making in hospitalized settings.
And I think this is very welcome because We know that a lot of nursing time is spent collecting the capillary blood glucose measurements in hospital. And if there's a way for that to be simplified to save some nursing time for sure, but on top of that, also provide more complete data for clinicians and the person in hospital to make decisions around treatment, I think that'd be great. But you're right, the one concern we have now is around accuracy. So if there's a simple algorithm that we could push a button and it would apply to each person coming to hospital, that would be great. So something to look forward to. Now, my final pick is what I think a really neat idea. Dr. Vera Lehman and colleagues from the University of Bern in Switzerland aim to develop a machine learning approach for non-invasive hypoglycemia detection using voice data. They collected 540 voice recordings with a smartphone in standardized euglycemia and hypoglycemia in 2 sequential clinical studies in people living with type 1 diabetes. 22 individuals were included. Using these data, they trained and evaluated a machine learning approach to detect hypoglycemia based on voice features. The 2 most effective voice tasks were reading aloud text of about 250 words, as well as rapid syllable repetition or diadochokinetic tasks. I think just saying that, diadochokinetic tasks, should actually be one of the tasks. But anyway, as a reminder for our audience, because you may not have thought about diadochokinetic tasks for a long time, this would be saying pa 10 times, so pa, 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 ta 10 times, ta, 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 ka 10 times, ka, 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 as well as pataka 10 times, and then buttercup 10 times. So this would be the rapid, repetitive sounds. Machine learning achieved high accuracy in detecting hypoglycemia with area under the receiver operating characteristic curve up to 0.9. This suggests that voice analysis may enable non-invasive hypoglycemia alerts. Considering the pervasiveness of smartphone and other recording devices all around us, this may actually end up being an interesting tool.
And it's really what we hear a lot from our patients' families and partners. And that is how the individual with diabetes is speaking that tips them off to say, hey, how about checking your sugar level? And so I agree, Al, it's a really interesting way of putting some quantitative measurement around this qualitative experience that we hear so much about from our patients. Well, this brings us to the end of the January 2026 episode of Diabetes Care on Air. A big thank you to Dr. Seth Berkowitz, Marshall Chin, and Mariana Socal for sharing their expertise with us.
And a big thank you to you, our listeners, for tuning in to another year of Diabetes Care on Air. Remember that Diabetes Care is continuing to take submissions of original art for consideration to be included on a future journal cover. Don't forget to subscribe to get notifications about new episodes of this podcast. Thank you for listening, and again, Happy New Year to everyone.